watching COPD and sleep as a part of RHA's Living Better Together COPD Week. Respiratory Health Association is a patient service and advocacy organization based in Chicago. Our mission is to prevent lung disease, promote clean air, and help people live better through education, research, and policy change. We welcome you to our COPD educational series, where we work to address current issues surrounding COPD management and care. Today, we are pleased to be joined by Dr. Herdegen, Associate Professor and Section Director for Sleep Medicine at Rush University Medical Center. By improving sleep quality, not only is the individual improved, but also the people around them and their overall health and associated health problems. Today, Dr. Herdegen will talk to us about the relationship between sleep and COPD. Dr. Herdegen, over to you.
Thank you very much. I appreciate this opportunity to talk, and I'm going to now share my slides. Great. Well, on any given day, I'm usually feeling like either the left picture or the right picture, and I think many of you also experience that. We're very dependent on quality sleep in terms of how we feel during the daytime. And I'm going to talk a little bit about the science, but also the practical aspects of sleep with chronic health conditions, including chronic lung disease. What I want to spend just a few minutes about is just understanding sleep, because sleep evolves over our lifespan. And for those who are doing daycare, for either your children or grandchildren or great-grandchildren, remember that the younger you are, the more sleep you tend to need. And of course, tantrums, outbursts, mood changes are very much influenced by sleep, especially sleep deprivation. But as adults, we should be getting about 8 hours of sleep. Now, that may not be all at once, and I'm going to show you something related to what your sleep is like at night, or sleep cycles, because it does change between children, young adults, and the elderly. And as we age, our sleep becomes a little bit lighter, that is less slow wave sleep, and it more fragmented, that is we wake up more. And so getting 8 hours of sleep as we age may result in a need for a nap during the day, and the nap is perfectly fine. Of course, the proper timing of the nap is really important, because naps in the evening will disturb our sleep at night, so properly timed nap can be very beneficial. The other system that we have that we don't quite recognize unless we travel to Europe or India or Japan is our circadian biological system. And that also influences our sleep. And I just want to point out, it's quite important that we have both this, what's called the homeostatic model of sleep. That is, the longer we are awake, the greater our drive to sleep is, and also a circadian rhythm of sleep. And balancing our circadian rhythm with our homeostatic drive creates this perfect symphony of sleep. And often I spend a lot of time in my clinic trying to emphasize that we need to coordinate both of these systems to optimize our sleep. So be aware of these things that I talked about as we start talking about sleep and breathing. So a couple of things to notice during sleep is that as you're transitioning to sleep, you might notice your breathing changing. And partly it's because our breathing, either frequency or depth of breathing, changes depending on if we're awake or if we're falling asleep. That is, we tend to take a little bit smaller breaths, or we tend to slow our breathing down during our sleep. And this is perfectly normal. And the challenge, of course, is if our breathing is not optimized, that shallow breathing can lead to an increase of carbon dioxide, or what's called PCO2. And we're vulnerable in different stages to different degrees. So we respond differently. There's also a change in response depending on the stage of sleep. And there's a difference between our response to carbon dioxide in different stages of sleep and also in wakefulness. And so we often need a higher CO2 to stimulate our breathing when we're asleep. And so it's normal for our carbon dioxide level, which is usually tightly regulated during the day, to increase during sleep. So in chronic obstructive lung disease, what happens to affect our sleep? Well, certainly there's coughing and wheezing that can interrupt our sleep. Sleep tends to be a little bit more fragmented. We have more awakenings, and we tend to have less depth of sleep. That is, we sleep in lighter stages of sleep. And the more severe our lung disease is, we tend to have more complaints about our sleep, even though it may not be completely objective in measurements of our sleep. The measurements, though, that we use are an Epworth score. It's a daytime sleepiness score, asking about sleepiness in passive situations. There's also sleep quality questionnaires. And in addition to breathing problems during sleep, there's also complaints of insomnia, that is, difficulty either initiating sleep or staying asleep. And because of that, there's this tendency to use medications to help with sleep, whether they're over the counter or by prescription. Many patients with lung disease, especially if they've lost about half of their lung function or more, do drop their oxygen levels at night. And there's, because of that and because of other things, including cardiac irregularities or arrhythmias, there's a higher likelihood of death at night. There's this association of dropping of our oxygen level, even more so in sleep than, for example, during exercise or during wakefulness. And so sometimes a wake time oxygen level can help predict nighttime dipping of your oxygen level, but it has to obviously be, you have to be aware of that risk and then decide what to do about that. So what we're trying to then understand is a little bit about how does lung disease affect sleep and vice versa? How does sleep affect our respiratory function or how we feel? So these are some of the questions that we'll delve into a little bit as we go through it. One thing to be aware of is that nicotine has an effect on sleep quality, snoring, higher risk of sleep apnea, difficulty either falling or staying asleep. And there can be nicotine withdrawal in the middle of the night, leading to sleep disturbances. And it's also associated with a phenomenon called restless legs, or in the middle of the night while asleep, it's called periodic limb movements. These are brief movements of your legs that can lead to awakenings or brief changes of sleep state that lead to fatigue or sleepiness. And there's compensation by drinking more caffeine because of all these sleep disturbances. Now, if you have sleep and COPD, that's called the overlap syndrome. And in general, it's thought that at least 15% of patients with chronic obstructive lung disease also have sleep apnea. But as you increase the severity of lung disease using gold stage criteria, the prevalence of sleep apnea also significantly increases up to perhaps 40 to 50% of individuals. So why is there this concern for overlap syndrome? And in general, it's because there's a higher complication rate of things such as respiratory failure or pulmonary hypertension, more severe oxygen dipping, also diabetes, obesity, and death. And here's a clinical study that looked at severity of sleep apnea and cardiovascular comorbidities. So the more severe your sleep apnea, the greater the risk of cardiovascular disease or metabolic conditions such as diabetes. There's also a greater risk of arrhythmias. Atrial fibrillation is one of the more common arrhythmias that occurs. And if you look at overlap syndrome compared to either COPD or sleep apnea alone, there's a significantly higher risk with the combination. Now, how do we treat this overlap syndrome of sleep disturbance or sleep apnea and COPD? And so I'll talk briefly about the different modalities of interventions. Certainly medications, inhalers tend to improve symptoms, and if timed properly, do not usually have an effect on sleep. Although theophylline, which is a medication when I was in medical school, very commonly used and much less commonly now, but it has been associated with effects on sleep because of its xanthine properties, which affects our desire to sleep or drive to sleep. We also know that there's been this increasing use of medications for insomnia. And so the more medical conditions you have, the greater the risk of insomnia is prevalent, along with the association of lung disease and insomnia in terms of either restrictive or obstructive lung disease. There's also this correlation of hypnotic use, that is sleeping pill use, and different other variables such as female gender or someone who smokes, mood disorders, depression, for example, anxiety. There's a higher association of hypnotic use. And there's, of course, then side effects and risk factors of use of hypnotics. So this is crash incidents in patients who were taking different sedative medications. We tend to try to use a little bit shorter acting medications rather than longer acting medications. There's also an association with emergency room visits. And so the use of hypnotics needs to be used cautiously. We tend to use shorter half-life medications, so medications that may last about 6 to 7 hours or so. There can be some carryover sleep sedation effects in the morning. There is a higher risk of falls with the use of sedative hypnotics. But in the right circumstance and in the right situation, they can be very appropriate. But a good evaluation and history becomes very important when considering the use of sleeping pills in patients with other health problems, including COPD. What is our primary treatment for insomnia? It's actually cognitive behavioral therapy for insomnia. And basically, in randomized clinical trials, these methods have been shown to be as effective as prescription medications. If you follow people beyond about 6 months, they're more effective typically than medications. And so we have a group here at our institution where we assess in a non-pharmacological way methodology to improve sleep, because we know it's as effective and often longer lasting. What are other interventions that have shown to improve sleep? And I'm a big advocate of pulmonary rehab or exercise. We know that exercise promotes and consolidates sleep. It improves the depth of sleep, or what we call slow wave or deep sleep. We also know in some questionnaire studies that sleep quality or quality of life is improved in patients undergoing pulmonary rehab. In the use of oxygen for COPD, it certainly has been used and beneficial for the appropriate patient. Typically, it's used for patients with a defined level of oxygen to saturation, and Medicare in general is defining this as at least 5 minutes of an oxygen saturation of less than 89%. And so I'll frequently order something called trending oximetry in the home setting, which looks at sleep-associated oxygen desaturation and how severe that might be in terms of determining whether it's the use of a nocturnal oxygen or daytime supplemental oxygen, or the use of non-invasive ventilation, which I'm going to get into in a minute or two. And so I just want to show you kind of a graphic of what sleep does, what sleep looks like in terms of oxygen saturation based on different stages of sleep. And REM sleep is our most vulnerable period for oxygen desaturation. You can see that here. These are 3 REM periods, and you can see that they're associated with significant dipping of your oxygen saturation. And because of that, the pulmonary artery pressures tend to increase along with a higher blood pressure during these stages of sleep. So with supplemental oxygen, you can see that the oxygen saturation dips are significantly less. So there's been a few large clinical trials, nocturnal oxygen treatment trial, and a Medical Research Council trial looking at supplemental oxygen. And in those, again, appropriately selected patients, there was an improved survival in those individuals using continuous oxygen. In general, the level is about 2 or 3 liters, depending on whether you're awake or at night. So there's, of course, as you know, with low oxygen levels, our body doesn't quite like that. And there can be other health comorbidities, the cardiac arrhythmias we talked about, the risk for coronary disease or heart attacks. And we know that oxygen in sleep apnea tends to improve the oxygen level, but not necessarily sleep quality or effects on blood pressure or daytime sleepiness. So that's why we're thinking about other modalities for the appropriate patient who has overlap syndrome of sleep apnea and COPD. Again, it does have an effect on oxygen levels. But we moved to something called continuous positive airway pressure for many patients with chronic obstructive lung disease and sleep apnea, because it's been shown to reduce the risk of death and exacerbations and improves exercise tolerance. Now, what is CPAP? I'm going to show you some pictures of some devices that are out there, and this is always a moving target. Some of these devices have been upgraded. But these are positive airway pressure machines. This is actually a portable machine. This device is not yet out there, but there's a lot of different modalities that we use for positive airway pressure therapy. In addition to the machines, there's a lot of different mask interfaces. And many of these don't look that appealing. The masks also very much are evolving and improving over time. And some are getting quite small. These are nasal pillows. This is a nasal mask. These can be bulkier. There are full face masks out there. There are full face masks if people cannot breathe easily just through their nose. Then we use full face masks that cover the mouth and the nose. So this is one of the smaller full face masks out there. There are also other therapies that try to treat sleep apnea, including oral appliances, and we use specialty dentists that are expert in this area of treatment of sleep apnea. Here's an example of one of them called the TAP mandibular advancement device. Essentially, this comes out, but basically you're turning a screw to move the lower jaw forward. By doing that, it tends to open up the space in the back of the throat. There's also positional training devices, occlusive valves, which have actually fallen out of favor. Radio frequency ablation or pillar procedures, two different procedures that have been used. There's also this device, which is the Inspire device that you might have seen TV commercials for, but essentially it's an implantable device that takes a wire that wraps around a particular nerve that controls the tongue. And with every stimulation, it moves the tongue forward, opening up more space in the throat and reducing obstruction. So it's a stimulatory device that's surgically implanted. And there's a pretty stringent selection process. Your weight has to be under a certain amount. The obstruction of the upper airway has to have a particular pattern of obstruction to it. So that's why there's an assessment and a direct visualization of the airway under anesthesia to look at that collapse. Well, we know from the literature that CPAP shows an improvement with risk of death. Just comparing the use of CPAP and with CPAP compared to just COPD alone, we know that treating the sleep apnea tends to have a better survival advantage. And also it reduces exacerbations of COPD. It's also another clinical study looked at even partial use. So 4 hours or less a day still showed improvement of survival compared to minimal use, 0 to 2 hours. So patients with overlap syndrome of COPD and obstructive sleep apnea do tend to have a reversal of their mortality, at least in this clinical study. And in those who looked at long-term oxygen or long-term oxygen with CPAP, there was a better survival relationship. Well, what about difficulty initiating and falling asleep? Because that's common. It can actually affect up to 30% of the population. The question is, can CPAP also help that? And in the appropriately selected patients, it did demonstrate a significant improvement of insomnia symptoms. Although that seemed to be associated with awakenings at night compared to falling asleep at night. So adherence also has a major effect on this. So if you use the device, you'll have a better effect, as you might imagine, than if you don't. The next process that we've started looking at because of technology improvements is non-invasive ventilation. And so what this is basically positive pressure ventilation using a mask that I showed you examples of, that vary pressure between breathing in and breathing out. It can also be programmed to try to assist breathing to a certain level, that is, provide a certain amount of air volume every time. And it can make adjustments to the air volume depending on breathing patterns, body position, sleep stages. And it can provide backup rates to support breathing even if the body decides to stop breathing. So it is associated with improved mortality in some retrospective trials. There's still a lot of information to know about this. And there's some recent clinical trials that do support this. Sorry, my slide's a little bit dated. But again, not very large randomized clinical trials. But if you look at non-invasive ventilation and survival, you can see that there tends to be a little bit of an improved survival, at least in the first several years. So we are performing non-invasive ventilation and following closely, and there are a number of settings on these machines that can improve comfort. And that really is a very individualized therapy for the appropriate patient. We also see that non-invasive ventilation's effective for both a condition called obesity hypoventilation. So, obesity hypoventilation is associated usually with an individual with a high body weight who has shallow breathing that's being affected by that weight around the chest wall. And you can see that there seems to be very similar hospital-free days in both COPD patients and those with obesity hypoventilation. So there's been a number of little analyses of smaller clinical trials that looked at non-invasive positive pressure ventilation or non-invasive ventilation. And in general, it's showing improvement. And it looks like I've reached the end of my slide talk. I hope I've stayed within the allotted time given to me. There's so many other things I'm sure I could have touched on of sleep. And so in general, in summary, sleep disorders are very common. They range from sleep apnea to difficulty falling asleep or staying asleep to leg movements at night called either restless legs or periodic limb movements. And these are all very treatable. And so if your sleep you feel like your sleep's impaired, there are very personalized solutions for most of these sleep problems that people might be experiencing. And I encourage you to not delay and seek out help, because we have very treatable solutions. And the quality of life in something very treatable and reversible can be dramatically improved. So thank you for your time.
Thank you, Dr. Herdegen. And thank you all for watching COPD and Sleep as a part of RHA's Living Better Together COPD Week.